ideally I should be following her, because we talk about the logic of progression as well. But in a way, it's right that this comes first before that, because I think as ophthalmologists, we're all guilty of the crime of managing orbital inflammation or a pseudotumors, founding them with steroids, not really having done that particular workup. So it's not so maybe practically this kind of makes sense as well. And we all know very well the old terminology, and I underscore old because we should not be using the term anymore, is pseudotumor of the orbit. So there are a few other synonyms that you might see in the literature or spoken language, non-specific orbital inflammatory syndromes or disorders, NSORS or NSOID. And a few years ago, it used to be called idiopathic. And as we know very well, as we start investigating, applying our knowledge of systemic immunological diseases to orbital inflammatory diseases, i.e. even thyroid for the matter, we are now able to narrow a lot of these conditions that we labeled as pseudotumors or IOIs. And so the idiopathic is becoming a smaller and smaller and smaller piece of the pie than what it was thought before. Okay? Here's an example of a patient who was presenting with us with a known history of hyperthyroidism, acute onset of redness. We just finished a session on thyroid orbitopathy. As always, they typically appear on a Friday afternoon. And obvious diagnosis, active inflammatory orbitopathy. Okay? But there were a few atypical things which prompted us to doing an investigation, imaging for him, and you can make out it's not the muscles which is a major offender over here. The muscles are not necessarily enlarged, but you can see a diffuse infiltrative lesion along the superior orbit and superlateral orbit. And incidentally, the eye on the left side, there's an interphone lesion as well. In other words, a lot of these patients present with other manifestations and sometimes other diagnoses as well, but may end up actually having inflammatory orbitopathy as well. So I'm going to give you a little overview, including the principles and concepts of management of these patients as well, and what is the driving principle behind inflammatory orbitopathy. There's only one inflammatory orbitopathy where you don't need a biopsy, and that's thyroid orbitopathy. So we will be covering that. Barring which, practically every other case should have a specific diagnosis or at least when possible biopsy before you start managing them as non-specific orbital inflammation. So the definition is all orbital inflammations are specific and controlled device, but unfortunately they all have similar common signs and symptoms and presentations as well. And that's why we think we've seen hundreds of these before. The manifestations may be similar, but actually the diagnosis may be completely different. Okay? There are specific nuances which are different to every ethnicity, the gender, age, and geography where it is. And the response to steroids is what actually helps us diagnose these patients, but unfortunately manage or even mismanage these patients, because all of them respond to steroids. So you think medically this is idiopathic orbital inflammation or non-specific orbital inflammation? No, still you treat the patient right, but with the wrong diagnosis in mind. And that again underscores the value of biopsies for these patients. And why is it important to categorize these patients appropriately? Because the prognosis changes depending on the nature of the diagnosis, and not all non-specific orbital inflammations are the same. So principles of management of these are, number one, the use of corticosteroids. You heard that in the thyroid orbitopathy talk. There was some evidence that non-steroids may help in a subgroup of patients, but surprisingly, for an inflammatory disorder, non-steroidal really do not do much for these patients as well. There used to be some information about radiation. Again, it's a treatment of last resort, not the first resort, so you should not be embarking on that. But of course, there's an increasing role of immunosuppressant therapy, and now in the current age of biologics that our rheumatology colleagues use is becoming more and more prevalent for this as well. So this is how I see orbital inflammation. First of all, to make sure you rule out pseudo-orbital inflammation. Dr. Santosh now showed slides of orbital inflammation with patients with retinoblastoma, extraocular extension, Bacillus orbital cellulitis, the picture. It's not an orbital inflammatory disorder. Okay, so pseudo-inflammations. Once you rule it out as a true inflammation, you have to make sure that you're not treating an infectious condition, because that algorithm comes completely differently. And once you determine it's a non-infectious etiology, there are certain chemicals which also can cause inflammatory disorders as well, pamidramate and all those things which give osteoporosis, can cause orbital inflammation. And then comes a huge group that Sudarshan is going to talk about, which is specific orbital inflammations. And the number one up there is Graves' orbitopathy, specifically highlighted IgG4 disease, and there's another condition which is sarcoidosis, which is now becoming increasingly recognized, especially in our population. And only when you rule all of these things out, that's the small group, and I think it upsets itself, but it means such a small topic. No, that's right. I'm just kidding. Okay? And it is quite significant and quite common in terms of frequency as well. It can be varied in presentation, can be unilateral, bilateral, can be a single episode versus a recurrent episode, and very initially, although we thought that there's a painful inflammation, there are patients with sclerosing over tumors that do not present anything at all. And once again, highlighting the role of diagnosis exclusion, biopsy is always highlighted. And I think we are overdiagnosed. There's one condition we're diagnosing a lot of this, and that's non-specific autoinflammatory syndrome. So here's why we talk about pseudo inflammation. This patient was on and off steroids for inflammatory pseudo tumor. She's got an infiltrative lesion right the superior lobe, easily accessible. Go ahead to a biopsy, comes back as a lymphoproliferative disorder. I don't call them lymphomas because the lymphoma is a pathological diagnosis. The treatment for this is completely different. Okay? So how do you go about diagnosis in a case of non-specific autoimmune syndrome? Of course, you do a complete and an extensive ophthalmic examination. It's very important to do a review of the systems because a good proportion of these diseases, especially in certain age groups, have systemic involvement in addition to organ inflammation itself. All patients should ideally have as complete an inflammatory workup as possible. We don't do a shotgun approach, but based on clinical differential diagnosis, we order the proper investigations and or now, in the past we used to call venous granulomatosis. We don't use terms like that anymore. It's granulomatous polyangiitis, angiitis, granulomatous polyangiitis, which is a specific term that we use, which now can be seen as presenting as idiopathic organ inflammation because all the lab tests are negative. And you can still see limited forms of these so-called venous granulomatosis. But if you do not do all of these investigations starting in those patients, then you're not really treating the patient with non-specific autoinflammation syndrome. We'll talk a little bit about imaging and finally some special situations as well. Okay, so the spectrum of patients is that patients can present with is most commonly anterior. Anterior, and you and I have all seen these cases of so-called scleritis, so-called scleritis, so-called sclerotinonitis. I think they still come under the category of non-specific autoinflammatory syndrome. Yes, we all know that they start with NSAIDs and steroids, they get better. Thankfully, it's a one-time episode, something that could come with inflammation. And that's one entity where the biopsy may be a little challenging. Barring which, you can get specific cases like dacryoadenomatous, as I shared before. You can get isolated oculomyositis. It's a specific entity that we use, not just the spiral myopathic inflammation, or oculomyositis as well. And the challenging ones are the posterior organ inflammation are right at the apex, where then the diagnosis may be easy, but biopsying that might be very difficult. And in the years past, one disease which was very difficult to manage is the sclerosing orbital pseudotumor we used to call. And this is one disease I think we are starting to make strides because of the advent of high-dose steroids aggressively at the earliest phase of the pre-fibrotic stage of the disease. We are now even able to see reversal of some of the fibrotic signs that we used to see in the past. So that's something I really want to take on board as well. And there can be varied presentations. Not all autoinflammatory diseases are acute or hyperacute. You can get indolent subacute, and finally the chronic sclerosing. And remember, some of these may have systemic presentations as well. What investigations do I use? Generally speaking, for more organ diseases, I go not ultrasound, but to CT or MR because I'm poor at ultrasound. But more importantly, you're able to make bilateral comparison. Well, same thing as thyroid and a lot of other organ tumors. Which investigation do I use? If I'm going to use it as a one-time deal to clinch a diagnosis, to make a decide on management, I go for a CT scan. There's emerging evidence of the radiation effects of CT scan and the late developments of cancer. So somebody going to require a recurrent follow-up investigations, then by default you go to MR. And MR can pick up certain features that the CTs cannot pick up, but that is a one-time episode that generally go to a CT scan itself. Okay? So make a proper diagnosis, do an appropriate workup, do an appropriate imaging, and then you go ahead and decide whether you're going to do an empirical management or you're going to do the tissue diagnosis. So the minimum workup you should do before you start managing non-specific autoinflammatory syndrome is disease-specific and disease-related and management-related. By that I mean you want to make sure the systemic diseases like diabetes doesn't exist, there's no tuberculosis, because whatever immunomodulatory agents you're going to give is going to kill the patient. So the treatment should not be killing the patient. So that's very important. And in special situations, you do an extended workup. Keep a very, very low threshold for biopsy depending on the clinical type of presentation as well. I don't think there's much role for knee aspiration biopsy, but by default most of them should be an incision biopsy. And this is relatively easy for anterior lesions, lateral lesions, and in difficult to access areas, you can even do a transient endoscopic atypical orbital lesions or intracranial biopsies in patients with things as well. But keep in mind, there is a possibility of sampling error. Either we didn't biopsy the representative site because biopsy is a very different part of the lesion than the central part of the lesion as well. So in our practice, it should be all cases until proven, until contraindicated. And the indications will be focal, anterior, accessible, and safe information as well. And these are situations where biopsy may be difficult, either because the patient is unfit for local or general anesthesia. As a rule, hard to sell an open biopsy for patients, children, especially the parents are unwilling. Diffuse sclerotionitis, we don't know where to go and do a biopsy. Optic perineuritis because the risk of visual loss. And the apical so-called Tolosa-Hunt-like syndromes where we end up not doing a biopsy, barring which you should be able to do a biopsy. So once you have more or less categorized these patients as truly non-specific, once again the same spectrum of management of corticosteroids, we'll talk a little bit of oral and IV methylprednisolone. NSAIDs are out unless in special situations, immunosuppressive therapy, biologics, and last is radiation. So this is my approach to inflammation. It's like terrorism. If you use a soft-hearted approach, you're not going to kill it. So, okay, but terrorism should be tackled rock hard, like how Singapore does. Okay, so you want to hit hard on these patients once you have a proper diagnosis, and that's where we use steroids. And we want to use steroids not in a half-hearted way, but good doses. Generally, in adults, it's anywhere from 1 to 1.5 milligram per kg body weight. Remember, in children, they don't respond to the standard doses. They may want to really quell the inflammation with a much higher dose, 2 to 3 to even 4 milligram per kg body weight. And that's how you quell the inflammation when we start tapering the treatment as well. In potential vision or life-threatening inflammatory diseases, you can talk about IV methylprednisolone, different dosage regimens as possible. The most important thing is duration. How long do you continue until you stop? Basically, you want to completely control all of the inflammatory signs until there's reversal to near normalcy before you want to start tapering the dose of steroids over the next few weeks to months, and that's arbitrary. And we'll talk about what happens when the inflammation comes back in a short while. And there are different forms of steroids which is available. So when you complete a course of steroids and there is a first sign of error, what do? Always make sure your diagnosis is right. And if you're sure about the diagnosis, that's when you consider the various disease-modifying anti-rheumatological drugs which are available, and all of which we are kind of familiar with as people who are managing uveitis and other inflammatory disorders, including thyroid atopic. But not all immunosuppressants are the same in terms of non-specific orbital inflammation syndrome. There's certain conditions like myositis where cyclosporin specificity is more effective than the other conditions as well. Cyclophosphamide, which is quite a legal drug in itself, is very specifically indicated and very useful for vasculitis and potentially life-threatening orbital inflammatory disorders. Myositis, again, methotrexate can be useful, but keeping in mind, when a patient does not respond to the typical drug of treatment, it could be either because they got your diagnosis wrong, but sometimes these patients have a genetic mutation which makes them unresponsive to these kind of immunological manifestations. You can now do genetic tests with these patients and they have antibodies, then you can actually switch them to a different class of immunosuppressant agents as well. And mycophenolate is readily available. It's quite expensive in our country, but something that immunologists are using it more and more in the management of these disorders as well. What is the role for biologics? Biologics are lethal, but also very effective, again, for a specific subgroup of patients depending on what the pathogenesis is. So basically, you are again familiar with these groups of drugs, which is anti-TNF-alpha agents, which is specifically useful. They are given in the form of injections. The patients come once a week or once a month with integrators and make sure to get all inflammation. Then they can keep on maintenance dose as well. You also know about rituximab, which is used for other immunological, including lymphoma-like disorders, but that's specifically targeted against B-cell mediated inflammatory disorders as well. They're quite expensive and again potentially lethal as well. So again, it's not really a cost issue, but a risk qualification issue as well. So this is the last slide I'm going to show you. Are all non-specific idiopathic or orbital inflammatory disorders the same? In children and adults, they're quite different. Number one, Adult organ inflammatory disorders are truly organ inflammatory disorders where there is a good proportion of pediatric organ inflammatory disorders have intraocular inflammation. These seem to be associated with a higher amount of eosinophilias. Full blood count does have value. We already talked about the higher dose of steroids in children compared to adults. There is a greater risk of bilaterality and systemic disease involvement in pediatric organ inflammatory disease compared to adult organ inflammatory disease. One, keep that in mind. You can have a higher recurrence rate. There's more likelihood of a pediatric organ inflammatory patient is going to require immunosuppressants rather than just one-time steroids as well. Only problem is there's a higher threshold for biopsy and the side effects are slightly different. So in summary, non-specific organ inflammatory disorders are not that rare. Actually, we should be making proper diagnosis. Always rule out one of the specific organ inflammatory disorders, either by systemic evaluation or serological testing as well. Keep a low threshold for diagnosis. When in doubt, don't think about doing the repeat biopsy because it's a sampling error we talk about. Manage them early, manage them aggressively, and when necessary, co-manage with this immunologist. So thank you very much.
Thank you, Dr.